So we're going to talk about plantar heel pain, also known as plantar fasciitis and plantar fasciopathy. We've got a couple of free resources here. This first one, the most recent one, is my article in the Physio First magazine, In Touch. Then you've got some pages in the 5th edition of my Sports and Soft Tissue Injury book by Routledge. And then way back in 2017, I wrote an article on plantar fasciitis in Co-Kinetic Journal. So this plantar heel pain article is available on my website and drchrisnorris.co.uk, and the details of that are on the last slide. So let's have a look at the plantar fascia itself then. So we know it's in the sole of the foot, and it's sort of instrumental in forming the sole of the foot. So it spreads from the heel bone, the calcaneus, towards the toes. And as it is attached to the heel bone, it attaches through an enthesis, which is a sort of a fibrocartilaginous attachment. So it sort of blends with the bone. The central portion of the plantar fascia, it's in three portions, and the central portion is thicker, and the two outer portions, so on the big toe side and the little toe side, are thinner, and they attach to the muscles in that area. So on the medial side, we've got the plantar fascia attaching to the abductor hallucis, and on the lateral side attaching to the abductor digiti minimi. So as we'll see later, the restoration of function of these muscles is important as part of the rehab. So as the plantar fascia stretches forwards from the heel, it's going towards the toes, and it attaches. So it surrounds the flexor tendons, within the sole of the foot, or coming down into the sole of the foot, and then it attaches into and merges into the transverse ligament going across the sort of knuckles of the foot. So it's got that sort of insertion at the front from the transverse ligament, and it's coming from the calcaneus. Now, interestingly enough, as it forms its enthesis, some of the fibers sort of spread backwards and along the posterior longitudinal line and sort of blend with the Achilles tendon. So again, in rehabilitation, this is a consideration that we need to be doing, calf type exercises as part of rehabilitation. And then just looking on the sort of medial surface, then we've got our sort of posterior tibial nerve coming down, splitting into two branches, on the the medial branch and the lateral branch. But also the lateral branch comes down, and it gives off, or the lateral plantar nerve gives off the calcaneal nerve, or Baxter's nerve, which is interesting with a view to our diagnosis. So what does it do? Well, essentially it links the rear foot to the forefoot. So we often think of the foot as being a sort of a passive, falling object, a bit like a brick really, that needs to be supported in squishy, sort of expensive training shoes. But in actual fact, we roll over the foot. So we've got a sort of a roll, which is the ankle joint. We roll over the heel bone, and we roll over the ball of the foot. So as we go forwards, initially at heel strike, the foot is quite floppy. So we talk about it as a mobile adapter, where it adapts to and deforms to the sort of surface, the uneven surface that we're working on. But as the knee goes forwards and presses the ankle into dorsiflexion, we want then to prepare ourselves to push off from the ground. And so the foot has to change from this mobile adapter to become a rigid lever. And it does that through the plantar fascia. So the plantar fascia we saw comes forwards and it is attaching through the transverse ligament to the toe. So it's sort of surrounding or going over the ball of the big toe. And as we do so, as we roll forwards, then we've got the foot relatively flat. As the big toe flexes, it pulls on the plantar fascia and it lifts up the longitudinal arch, the medial longitudinal arch. And this is known as the windlass effect. And you can see that on this slide, that as we bend this subject's big toe, the medial longitudinal arch is lifted. And we can use this as a form of assessment to assess, firstly, the height of the arch, but secondly, whether that arch is maintained in weight bearing. So as we go forwards, then we're using our arch, and the sort of breakdown in that mechanism is one of the considerations in plantar heel pain. So what is it we see? Well, it's pain in the sole of the foot towards the heel particularly, and it occurs as so-called first step pain. That is, you get pain when you get out of bed in the morning, or if you've been sitting for a long time. The first couple of steps, first 2 or 3 steps are quite painful, and then it starts to ease off in the early phases. And later on, it doesn't ease off, and we get pain made worse with prolonged standing or prolonged walking. So people say, well, if I stand up at a meeting, after a period of time, the first couple of steps are painful. If I'm walking my dog, I'm limited with the amount of time that I can spend on my feet, and it really hurts. And if I go too far, I've got to sit down before I can come back. So essentially, that pain is limiting walking distance, and that's going to have, a perspective on fitness and sort of health of the lower limb in general. And patients often describe it as an acute localized pain. So it feels like I'm stepping on a stone, that type of pain, and it can spread forwards then as a burning sensation from the heel to the medial aspect of the heel, right onto the inner aspect of the foot. So what do we know about this condition? Well, the first thing is that it's relatively common, and it seems to last for a long time. So about half of individuals say that they still have symptoms of some shape or form up to 10 years after onset. So it is very much a chronic condition. It affects about 10% of the population, more common in the elderly, in obese individuals, and in the sporting population, particularly in runners. And the risk then, linked to this first statistic, then the risk of having pain 1 year after your initial onset is about 80%. So, it's quite common that it's a long-term condition. And there are changes that we can see. So we can see changes at the heel on x-ray, so a heel spur, and we can see changes in fascial thickness on an ultrasound scan or an MRI scan. But the interesting thing is that there isn't necessarily a direct impact between those anatomical changes and recovery. In other words, sometimes you can find that somebody has no symptoms, so they completely recovered, but actually the anatomical changes haven't completely recovered. And this is something that we see in various conditions, isn't it? Where, hamstring injuries, these types of things, where, we don't necessarily need full anatomical recovery in order to get full functional recovery. All right, so these are the scans that we're seeing then. So this is where the skin would be. This is the heel bone, the calcaneum, and this is our plantar fascia. We can see these sort of parallel, thin, faint lines, and the plantar fascia sort of goes and it merges with the calcaneum. So in a condition where we've got the plantar fascia, plantar fasciitis, what we're seeing then is a change, a hypoechoic area. So in other words, where the ultrasound can't get through easily, and we start to see an alteration in the bone itself. So what we're seeing here is a thickening of the plantar fascia and an irregularity. So this is flipped round, so the heel is to the side now. But we're seeing a sort of an irregularity where this plantar fascia is attaching to the calcaneum, and we're seeing an increase in thickness in the plantar fascia. So those are the sort of signs that we're looking at. But we need to beware that not all pain in the heel or in the sole of the foot or on the medial aspect is plantar fasciitis. So we need to sort of think, well, what have we got around here? Well, clearly we've got the medial malleolus. We've got pain from the heel spur, which would be more a sort of a point pain directly onto the bone. We've got the plantar fascia insertion itself, which would be slightly forwards of that. We've got the posterior tibial tendons, which are coming down and sort of wrapping under the malleolus. So they may be, causing friction. We've got the tarsal tunnel itself, where you've got your flexor retinaculum, as we'll see later on in the slides, where the nerves sort of loop underneath. Then we've got the highest point of the medial arch, which is our navicular, and we want to know if the pain's coming from that, but we also need to be able to find it to assess it. We've got this nerve that I mentioned, Baxter's nerve, which is sort of starting off lateral and coming medial. We've got the calcaneum itself, and we've got the Achilles tendon insertion, which is obviously coming right down below the Achilles, right into the heel. So we need to differentiate where the heel pain is coming from and whether it is true plantar fasciitis or whether it is just an apparent plantar fasciitis. So this tarsal tunnel then that I mentioned is this sort of hollow area, as it were, underneath the binding, the flexor retinaculum, which stop the sort of flexor tendons from going ping. And under that we have the nerves coming down. So we've got our tibial nerve, our posterior tibial nerve coming down, and then splitting into medial and lateral plantar nerves. And then we've got our calcaneal nerve, the Baxter's nerve, sort of coming off that and sort of finishing just where the problem is, if you like, just in front of the medial tubercle of the calcaneum. So we would need to assess where that pain is coming from, and we use a tarsal tunnel test. So essentially what we do is we wind up the foot with the plantar fascia, so we're sort of flexing the big toe, we're everting, and then we're dorsiflexing to try and really tighten the plantar fascia, and then we're palpating the tibial nerve, the posterior tibial nerve, and seeing if we can reproduce the pain that the person describes in the heel, and we get that maximum eversion, toe extension, that sort of stretch, and then we palpate the nerve and we hold that position for some time. So I've put 10 seconds there, it might be up to 30 seconds to see if we can reproduce that. Okay, so what causes it? Well, before we go into this, we need to take a little bit of a sort of a segue and say, well, let's have a look at the difference between the cause of something and something that simply occurs more or less at the same time. So if I bash my head on a brick wall, I get a bruise, and that is the cause of my bruise, bashing my head. But if I walk close to a brick wall and I happen to have a bruise on my head, we can say, well, the two occur more or less at the same time, but one doesn't lead to the other directly, so that is a correlation. So we've got a number of things which are correlated, i.e. occur at the same time, or may occur at the same time as plantar fasciitis. And we've got a number of things which we can show statistically definitely prove it. So body mass index, the heavier you are, seems to be linked to plantar fasciitis. Reduction in ankle dorsiflexion range and reduction in first big toe joint range seem to be linked to that. And that would confirm what's happening with the windlass effect, wouldn't it? But correlated to that, we've got how long you spend standing. So some people describe that. An alteration in foot biomechanics. So I just bought a new pair of shoes, or I changed the surface I'm on. An alteration in the appearance of your foot, so how your foot appears, whether your arch is lower or not, but more to the point, the navicular drop test. So if your arch is high, or if it's normal in sitting, when you stand up, does it flex down, does it flatten down, or are you able to maintain it? And then Jack's test, which is where you look at the arch of the foot and then you flex the big toe and see what happens. So if they are very, very, hyperpronated, you may not be able to flex the big toe. But if you put the foot back into a more neutral position and they can flex it, it implies that, an orthotic may be useful. All right, so we can say that certain things are we can show with research that they cause things, or they are correlated to them. But of course, we've got to remember how research is done. It's taking a population and saying, well, what occurs in the average, the mean value of that population. But clearly, the individual patient that you have in front of you is one of the population. If the population is 200, there might be one of them. And you have outliers, don't you? So where you have the most common mean value, you have these outliers. So it may be that your particular patient actually benefits from an orthotic or manual therapy or acupuncture or anything else that research has suggested isn't directly correlated with this condition. So we have to remember there's a difference between statistical significance and clinical significance. So statistical significance being we can prove it with stats, with maths, whereas your clinical significance would be what does it mean to that individual patient. All right, so what is it that we're going to do to manage this condition? Well, this would be based on the evidence. So it's based on a number of different papers, but this particular one I'm quoting is from Dylan Morrissey, because it's a systematic review and expert clinical reasoning and patient value. So in other words, it's pretty high power. So in the core approach, what seems to work most often is lengthening, stretching, putting a stress on the plantar fascia. Okay, so we can say, well, stretching will do that, but perhaps other things will do it as well. Some form of foot support, so typically low dye taping or a plantar fascia specific taping, and some sort of education, getting the person to understand about load management, pain, the nature of pain, footwear, other things that can affect it, such as body mass, for example. So that would be our core approach. And then, to go with those, so sort of adjunctive interventions, things such as shockwave, because we've got evidence that it seems to work, the use of orthotics or simply footwear advice, some form of resistance exercise, because we know that muscle wastage is occurring here, possibly some form of needling, be it dry needling, acupuncture, corticosteroid, platelet-rich plasma, so PRP injections. These have been shown sometimes to be effective in some papers and not in others. So let's have a look at the sorts of things that as therapists that we can do. So we need to look at this and say, well, in the acute phase, what I like to call the reactive phase, we want something for short-term pain relief. And you might say, well, statistically, that's not important because it only gave the patient 2 days pain relief. Well, if you've got intense pain, you can't walk your dog, you can't stand up, and you can't hardly sleep because of it, 2 days pain relief is meaningful to you as a patient. So it is clinically significant. So things such as self-massage, massage with a foam roller, massage with a ball, these are all things which will give a little bit of relief, which might be meaningful to the patient. More to the point, it's something they can do themselves. So if it does only give you 2 days pain relief, and you can only see your physio once every 2 weeks, well, the chances are that you can get improvement from your physio, which will last for a few days, and you can keep that going by some sort of home management. Shockwave we'll look at later, so we've got evidence that that seems to work particularly in longer standing cases. So I wouldn't be using it in the reactive phase, in the acute phase, but as people start to recover, I would start to use that. If the big toe joint is stiff, then mobilizations are likely to be helpful. If it isn't, they probably won't be. Similarly, stretching where you can palpate the pain and the plantar fascia seems to be tighter would seem to work. So where the great toe is limited in its movement, plantar fascia is likely to be tighter. Taping and orthotics I would consider more so in the acute phase, so the reactive phase. As they move into the recovery phase, I would argue that those are useful to get the patient to be able to engage in rehabilitation earlier or more thoroughly. And a progressive loading program is what we want. So loading for the inert structure, so the plantar fascia, so it's not a muscle, but also progressive loading to build up the muscle. All right, so why shockwave? Well, because we have evidence that it seems to work. So shockwave seems to work in individuals who have a long-standing condition. It seems to work through cavitation, microjet formation, etc. So it's affecting the tissue directly. About 70% of individuals say they get some sort of relief, and that some sort is measured on a composite heel pain score. So it's an accurate measure of first step pain, pain during activities, pain to the application of focal pressure. Does it last? It seems to. So individuals who have shockwave treatment are often described that the treatment, the effect of the treatment lasts for up to 2 years, or it's measured for up to 2 years in various different papers. And one can argue that that is an indirect effect of the shockwave. If you're pain-free, you can walk, you can go and exercise. So is it the walking and the exercise which has improved? We don't know, probably. But the interesting thing here is that in these particular papers, there's no difference between focused shockwave and radial shockwave. So, and it may be that later research sort of comes out to modify that. But at the moment, they both seem to be equally as good. If we're putting taping on, we can choose. So this is your classic low dye taping, where you put an anchor across the forefoot and then you loop around the heel. Now it's a continuous tape, so it goes around the loop, so it's relatively easy to apply, and to an extent it will control the heel. So if you've got somebody who is pronating their foot because of the heel dipping out, so the so-called valgus heel, then this may be, this may help, as well as, orthotics and various different things. This is your plantar fascia specific taping. So again, we've got an anchor across. We also have an anchor around the heel, because with this, the low dye surrounds the heel. This one attaches to the heel in 3 or 4 strips. Takes a little bit longer to do because you've got to tear off each strip. So if you've got to tape 10 people, you might choose this one. But it has the advantage that you can vary the tension in the various strips. So you can say, well, I want more tension on the medial strip, less on the lateral, for example. And these can be incorporated with padding. So you could put a medial arch pad in. And I find it easier if you're putting a medial arch pad in to use the plantar fascia specific taping than the low dye taping. But that's up to you. Stiff big toe, so hallux rigidus, hallux valgus, hallux, my toe is stiffness. What we do is mobilize, and typically axial mobilization, so trying to make the toe longer, and AP moves, so AP glides, tend to be better. And what I will normally do is get them to flex the big toe up against a wall, mobilize, flex again. Do I increase the range? Do I reduce the pain? If I do, well, I'll use that technique, and I'll keep using it, providing it gives them some sort of relief. I might even get their partner in and teach them how to do that technique. If it doesn't give any relief, well, it's probably not relevant. It's as simple as that. It's a sort of it's a trial and error thing. And here we've got sort of self-applied techniques. So here we've got self-massage, and you can do that with your fingers, you can do that with your thumb, you can do it with a golf ball, you can do it with a foam roller. Either way, all we're doing is putting point pressure onto the plantar fascia. So that's going to have an effect in terms of pain, so hopefully pain reduction, but it's also going to have a sort of mechanotransduction effect. So you might get a little bit of a change in the structure of the plantar fascia if you do it heavy enough and you do it often enough. So that's not going to occur if you just do it once a week. But if you can give the patient that and say, we'll do it twice a day, you've got a chance. And then we want to flex the big toe, but because of the windlass effect, what we're going to do is combine it with big toe flexion. So this is the position we were in when we looked at that windlass test, wasn't it? So flex the big toe, have the heel on the ground, press the knee forward. So this is the knee to wall test with the big toe flexed. Make sure that you're taking the weight equally over the whole of the foot, because you want to maintain the height of that arch and you want to hold that. So, we might build that up to 10-second hold and increase that. So rather, not sort of pumping into it. This is the short foot exercise. So we want to increase the height of the arch. Now we know that the height of the arch is partly due to the plantar fascia, and the plantar fascia is controlling that as the foot changes from its mobile adapter to its rigid lever. But what is it that can actively control that? Well, clearly it's muscle. So what we're trying to do is take the weight to the little toe side and pull the big toe and the heel closer in. So we're not trying to flex and scrunch the toes. We want to keep those 2 points, the heel and the big toe, down and increase the arch of the foot. So we're going to do that in sitting. We're going to do it passively to start with to get the message across to the patient. Then we're going to do it in sitting. Then we're going to do it in partial weight bearing, and then we're going to do it in full weight bearing to really work that foot. All right. So we're talking about muscle now then within the foot rather than the plantar fascia. So what is the logic behind this? Well, the logic was, well, two things really. Firstly, that you can control the arch of the foot passively or actively. So you can increase and reduce the arch of the foot, or it can be increased and reduced simply in the act of walking. So we know that the abductor hallucis and the abductor digiti minimi are attaching into the plantar fascia. And we know that there's an element of the plantar fascia which is continuous, which is with the Achilles, which is obviously continuous with the calf. So when we look at this, we start to see that muscle wasting is common after pain and deconditioning, so with a knee injury or anything like that. So it's no different than the foot. So we get a reduction in foot muscle volume with this condition, and that's been shown in a number of papers with Osborne's papers from 2019 where he looked at this, or she looked at this, and then from 2023 where they looked at a program to cause development of this. So we've got that reduced strength in ankle dorsiflexions, inverters, everters, and foot muscle volume. All right, so what we do is we exercise that, and Osborne describes those exercises in the papers, but these have also been taken by Tom Goom and Liz Bailey, and they've sort of put these together in a nice little progression of free posters which are available, called the Lithe program, which I think stands for Liz and Thomas's something or other. But essentially it is a program, progressive program. And you can do similar sorts of things. So we did one of our students did one where we got a QR code, did the various different exercises, scanned a QR code so patients can then scan the QR code and see a little video of the exercise. And that's, again, freely available online. But these are the sorts of things that we want then. Work the big toe, work the other toes, some sort of heel raise, some sort of short foot exercise, get the toes moving, and then build it into function. So this is a band resisted hallux flexion exercise. So on this one, the band should be over the big toe as it is here, but you're pushing the big toe down to the floor and then encouraging walking barefoot at home, particularly. This is resisted, toe flexion of the other toes. And so, we're seeing the volume of the muscles within the sole of the foot increasing. Here we've got, toe spread exercises. So pressing the big toe away from the little toe, because we saw that those muscles were important. And, we often see in things like yoga and Pilates, people complain if they've been doing it for a number of months that their shoes don't fit. And that's because the foot was squashed into shoes, and now it's going to chance to broaden, and the foot muscles are building back up again. And so here we've got our typical calf raise modified using that windlass action again. So flexing the toes, taking the weight up, and being cautious that we're taking it through the whole of the foot. We're not just taking it on one side. So we're, getting everything to work. And then we're doing those exercises, building it more into function. So this is a lateral walk or cowboy walk. This is walking on a wedge surface or an uneven surface. And this is differentiating the heel from the forefoot. And these are sort of commercially available sort of foot exercises, but you can as easy make one with something solid here, in this case a weight disc and a foam pad, and you can differentiate heel from forefoot and regain control of that. Okay, so that's a very rapid run through. Those resources are available on my website, drchrisnorris.co.uk, and I'll share a few other things on social media as well, and those are my sort of taglines. All right, thanks for watching.